Hi, good evening, everyone. I'm Dr. Philip McMillan, and today I'm sharing an interview. So I'm not interviewing the person, but I want you to watch an interview that has been done on the Diary of a CEO with Steven Bartlett with Dr. Aseem Malhotra. I think this is a very important interview. It's a long interview, and I'm just doing a few clips from it with the encouragement that you should listen to the whole thing. He's asking the big question, or in the presentation, they raised this question: did the vaccine have a net negative result across the pandemic? This is an important question and an inconvenient one for much of the scientific community and as well the political class who had mandated vaccines. And what they don't want to do is go back to this kind of analysis. So, even just in the past week, I think I saw another paper come out that was highlighting the fact that vaccines save so many lives from severe COVID. And I wouldn't deny that it had an effect. But the principle with medicine is looking at all cause mortality and studying carefully whether or not your intervention has an overall benefit. It's kind of like aspirin. There's a reason that aspirin is not given to everyone all the time because there is a risk of complications around it, with bleeding in the stomach being one of them. And so, therefore, you have to think about the risk benefit for each patient. A 16-year-old who has no heart disease and no significant risk factors being on aspirin is more likely to cause harm than benefit. And so when we think about any intervention in medicine, we always take into consideration that overall risk factor, and that's what we call all cause mortality. And this is partially what was touched on with regards to the interview. Now, Dr. Malhotra is a cardiologist, and so he was specifically interested in the context of what was happening in terms of heart disease. And so I'll jump first to the interview, show you a short clip from it, then I'll jump back so that you can see a little bit more about what was happening. Let's listen to what he was saying in this section when he was talking about the association with heart disease.
The quality of life deterioration that happens with people who are diagnosed with heart disease that may not be able to exercise very much because they get pain in their chest because of a blockage, or they may develop what we call heart failure, where the pump function of the heart is affected because of blockages or because of a previous heart attack that they survived, and therefore they can't actually do the activities they want to enjoy. And that's, way bigger. In fact, that's, just as important as of course, the premature death rate. So, no, it's a massive issue. And it's interesting, Steve, that you mentioned the image side where people think about excess body fat and big muscles and that kind of thing. And that also plays into a certain culture and mindset that I think detracts from us actually addressing the root cause of many problems with society today in our health, which is not related to image, actually. It's about the basics of reducing stress, about our social interactions, etc. To some degree, obviously, what we eat is linked to how we look. But absolutely. I think it's not something people really think about enough, often until it's too late.
How does it impact women? Because we mentioned it being the single biggest killer of men, I think, in Europe, you said. What about women?
It's not as bad for women. And part of the reason for that, Steve, is, and traditionally, women on average will live up to 10 years longer than men.
Right.
And the reason for that is that women don't tend to develop heart disease.
I'll pause here and we'll come back to that in just a few minutes. But I'm just giving you a clip, a bit of a taste of what he's talking about in terms of what has happened around the pandemic and the impact that it had on the heart in terms of what was happening. Now, I'll show you another clip here where they're looking at whether or not there was increased inflammation with regards to the heart and vaccination. Just take a look at what he was saying here.
A huge jump. Like, just to give you perspective, Steve, if I today decided that I was going to just consume junk food, all my meals, right? I was going to smoke 20 cigarettes a day. I was going to stop exercising. I wouldn't get anywhere close to increasing my risk within 8 weeks. And the mechanism was for inflammation. And I thought, I know heart disease is a chronic inflammatory condition linked to lifestyle. So if this is even partially true, it means that the COVID vaccines may be causing inflammation around the heart. And that means that many people are going to have an acceleration in heart disease. And that may explain what happened to my dad. But that was only one bit of data. Of course, a good scientist knows, okay, it gets you thinking. It's a hypothesis, potentially, obviously some data, but it's not enough to make it more than likely at this stage. And within 2 weeks, call it Providence or whatever else, I got a phone call from somebody who I know. I consider him, one of the smartest cardiologists, very high integrity, from a very prestigious institution. And he called me up and he said, Aseem, I've got something to tell you. I'm very upset. He said, a group of researchers that I'm linked to in this institution had accidentally found, and this has nothing to do with blood tests or cardiac risk, through a very high-tech imaging of the heart modality they were using, that there was inflammation of the arteries, which would cause obviously potentially heart attacks, that was there in the vaccinated, but not there in the unvaccinated. The lead researcher sat the team down and he said, guys, I just want to make this clear. We are not going to explore these findings any further because it may affect our funding from the drug industry. Now, obviously, people hearing this are going to think, wow, sounds corrupt. This is something that has been a big problem within medicine for a very, very long time, which isn't getting an airing. But it didn't surprise me of that, but it was still quite shocking. But for me at that stage, Steve, it was, okay, at the very least, I should ask the question. And I was nervous about it. I had been someone, took the jab myself. I went to Good Morning Britain, and very early on, when they were just offering it to high-risk people, to say that I think that this is probably safe and people shouldn't be worried. And this was, again, specifically to address people from Black and ethnic minority communities, because there was a lower uptake amongst those communities, partly also because they are often amongst some of the most marginalized members of society, and they have less trust in authority and government. So you can see how the psychology plays in there. And I convinced a friend of mine who's a film director, Gurinder Chadha, who directed Bend It Like Beckham. You might know some of her movies. And we went on together in Good Morning Britain to say, listen, I think this is fine. So I had all of that. And so I was, in many ways, I was indoctrinated. And there is, and people don't like to.
I think I'd pause here. That bit that he said with regards to the heart inflammation is extremely important. And it's a similar thing that occurred with regards to PET scans, where they noticed in the vaccinated heart there was higher glucose uptake, which usually indicates an inflammatory process. It could be other things as well. And this characteristic changed in that cohort. Now, everybody knows that the first person who comes up with an issue around the vaccine is likely to get shot down. And this would be why the researchers were afraid to do any further research. And this is something people don't get. There is no evidence of doesn't often mean there is no evidence. It often means that the research hasn't been done. And the research is not done because funding is so tightly affiliated with the industry. And if you do research that is going to affect the industry that is funding you, that goes against what you want from a financial point of view. People may argue from an ethical point of view, that's a different question. But the point is that this is one of the main drivers why some of the critical research that we need, especially like, for instance, I look for autopsy data, hasn't actually been done. Really critical pieces of information. Now, just to follow up on what he was saying about the evidence with heart disease, I'll show you here a very critical paper that came out that caused a lot of storm in the UK, but it was that relevant at the time. And this paper was looking at excess mortality in England post-COVID pandemic, implications for secondary prevention. And so they were looking at the period 2022 to 2023. And you just have to look here is that at the time, the UK Office of National Statistics, they found that there was a 7.2% increase in the UK in the period of 2022. And this was comparing the 5-year average, excluding, so this is between 2015 and 2019 before 2020. That was a 7.2% increase. It's important to note that actually they have changed the recording statistics so that that kind of more simplistic measure is no longer used. And so when they use the newer methodology, it tends to show much less of significant excess mortality rise. But this was still relevant at the time because it was above the 5-year average. Let's go back to this paper again. In 2023, they found that it persisted, and it was 8.6% in the first half of 2023, in the first 6 months of the year. So this was rising year on year, excess deaths. I don't think this will be any different now if we use the old measurements. What I'd found at the time when I'd mentioned this some months ago, they looked or they considered the causes of excess deaths were likely to be multiple, could be including direct effects of COVID, acute pressures on the NHS acute services with poorer outcomes from episodes of acute illness, and disruption to disease detection and management. You will notice that in this analysis, there was an elephant in the room that was not included. And that had led me to use the concept of elephant in the room because I couldn't say at the time that this was possibly the cause. And I then coined the term elephant in the room because it needed to be said but couldn't be said. That was how bad at the time it was with regards to raising questions around the potential risks with regards to vaccines. It's a little bit better now, but I still have to be very cautious about what I say with regards to that. In terms of what else the paper had said, it highlighted as well that you had here. So when they looked at middle aged adults, 50 to 64, in that 13-month period, the relative excess for almost all causes of death was higher than seen for all ages. However, deaths involving cardiovascular disease, heart disease, were 33% higher than expected. And when specific to cardiovascular disease, deaths involving ischemic heart disease, so that's heart attacks, angina, and so on, that was 44% higher. Similarly, cerebrovascular disease was 40% higher. So these are very, very significant findings. And this was published in the Lancet, the regional Lancet. So it shouldn't have been ignored. And when you think about what happened with Mr. Bridgend, who was an MP at the time, raising the questions about excess deaths and the lack of interest. When that kind of data was there, it was inconceivable that the government was not interested. And it truly raises the question as to whether or not we should even be looking at excess mortality generally, if when we see patterns, they are not relevant to be investigated. The other part of the paper highlighted another point, which was that when you looked at the place of death, when they looked at from the 3rd of June 2022 to the 30th of June 2023, there were 22% more deaths in private homes than expected. Now, this was a huge question mark for me because I understand how the system works. And if patients are end of life, they can die at home. But I know how difficult it is to get an end of life patient home with all the care packages and the support. And what we do is fast track information to get people out of hospital. So I know that there wasn't a 22% increase in terms of this cohort of people getting out of hospital who you expect to die. So the fact that people died at home oftentimes indicates that these were unexpected deaths, somebody who died in their sleep. Now, you could have things like suicide, that could be possible, but I think when we looked at the trajectory over time, suicides were not that much higher than the previous periods. So it oftentimes will point to sudden adult death, and that oftentimes means either a massive clot to the heart, with to the lungs, PE, or some kind of cardiovascular arrhythmia, not even a heart attack. A heart attack usually gives people chest pain and they call an ambulance. So a heart attack doesn't necessarily kill somebody at home. They may die in hospital if they have a massive heart attack. But for somebody to have an arrhythmia, an abnormal rhythm, that could be because of inflammation of the heart. So these are very, very important trends that needed to be delineated. And what I would have wanted to see in that increase in private homes was whether or not this was occurring in younger age groups and what was the significance of it. I'm going to play you another clip from the video just so that you can hear about this question specifically with regards to potential harms long term. What was Dr. Malhotra's take on this?
But what's missing is that actually, okay, is there a benefit that's greater than harm in certain age groups? But we can indirectly answer that in a second. So that was the original trial. So on average, it was more harmful than beneficial. Okay. But even before talking about all age groups, Steve, a 1 in 800 harm rate for a vaccine is completely unacceptable in the sense that we have pulled other vaccines in the past for much less harm. The swine flu vaccine was suspended globally because it was found to cause Guillain-Barré syndrome, a debilitating neurological condition, in 1 in 100,000 people. Rotavirus vaccine was pulled in 1999 because it was found to cause a form of bowel obstruction in children at 1 in 10,000. So you've already got a harm rate of 1 in 800, irrespective of, right? So that first and foremost should be a red flag to say, hold on, this is too much.
When they say harm rate, what's the range of definitions of harm?
Well, in this one, they categorize serious harm as it caused you to be hospitalized.
Yeah.
It caused a disability.
Okay.
Or something that was life-changing. Now, of course, that can incorporate lots of different things. But of those, and I spoke to the lead researcher, I know work with him on other things, 40% of those serious harms were actually related to clotting disorders like lung clots, heart attacks, etc.
Let me make sure I'm super clear here because I don't understand the data you're citing. So you're saying that they found 1 in 800 people would have serious harm or harm?
Serious harm.
Serious harm.
Serious harm.
1 in 800 people had
in the trials. 1 in 800, yeah, 1 in 800, serious harm, right? Now, just to give you perspective so you can balance it out, just because this is important, it's a question you've asked is really important. We didn't have any good real world data at that point on can we separate vaccinated from unvaccinated to look at what the hospitalization rate would be for COVID, for example, in people who took the vaccine versus the people that didn't, according to age group. That data in the whole world, the only country to make that data available was the UK. And they did that in the beginning of 2023, so January last year. And what did that show? After 2 doses of the Pfizer vaccine, Steve, if you were over 70, so this is the highest risk group, you had to vaccinate 2,500 people to prevent one person being hospitalized with COVID.
And this was with the different strain, the Omicron strain, because the original strain was...
Yeah, it was, you're right. It was with the Omicron strain. So that was still, but it gave us a ballpark figure that even that, so it's like, so say a patient comes to me and says, Doc, what are the benefits of this drug as a prevention, whatever else? And I say to them, well, if you take this, there's a 1 in 2,500 chance it will help you, prevent you being hospitalized. I'll be honest with you, Steve, I mean, in medicine, in all the drugs I've used and all the data I know about different medications and heart disease, etc., that figure, I mean, it's a very serious issue, but that figure is a joke. I mean, there's nothing of such poor. And then when you get to people under the age of, say, 50, you're talking about having to vaccinate maybe several 100,000 to prevent one.
Is that relevant for the first strain of COVID as well? Or do we not have the data on that?
Because we don't have that data on that. We do, in my paper, which I published, actually, we did have some data on Delta. And if I remember correctly, the data on the over 70s, there's also problems with this a little bit because it's not corrected for other factors, such as socioeconomics, etc., risk factors that might make people more vulnerable. So if I remember correctly from that paper, if you're over 70, that was about 1 in 250. Delta was the worst strain, actually. So about 1 in 250. Okay.
I'm on the British Heart Foundation website. I'm sure you've read this.
Yeah.
Just to
so I think that this is important stuff. And as I said, I'm encouraging you to listen to the whole interview. And this is the thumbnail of it in case you come across it. So about 2 hours long. But take a look at it and make your own judgments. My view is that what we had, and when I was looking at this from the perspective of autoimmunity, so this was the way I was looking at the pandemic, and there, this is where my concern was, is that I thought our research was pointing to the fact that the virus, the cytokine storm that was triggered by the virus, meant that the primary mechanism was more like an autoimmune response. And that was what we were researching. Now, if that was the case, meaning that if the scientific community had accepted that, they would have had to think very carefully about how you stimulate the immune system. What are the risks? And so when I pull back and look at it from an autoimmune perspective, seeing these kinds of outcomes don't surprise me at all, because the problem, and this is really important, I break this down in some of the courses I do. The virus, the infection of the virus in a small number of people can cause a pneumonia, a viral pneumonia, where they get short of breath. And unless they have underlying lung disease, they're not going to die from it. What kills people is the cytokine storm, where they get little clots blocking up the blood vessels going to the alveoli. And literally, they will lose 90% of their oxygen exchange capability. That group of people will end up on intensive care. The trigger or the mechanism that is causing the microclots is more about the immune system. That is not the virus. So, as long as you understand that simple differentiation, where the immune system, it's like an overreaction of the immune system, that is what does the destruction. And so, therefore, if you are going to stimulate the immune system, you have to take into consideration the question is, will you cause that immune system to become overreactive? And so, therefore, when further exposure of virus occurs, you have abnormal immune responses. This is what they found in early research when they were trying to make vaccines for SARS-CoV. This was from 2003. Interestingly, when I spoke with Professor Petrovsky, his vaccine, which was protein based, didn't cause the immune pathology that almost all the other types of vaccines did. So, this is the foundation of where the questions lie. The problem is going forward, autoimmunity around COVID increases with infection. So, a lot more people, because of the infection, will have more autoimmune disorders. And so, no matter what we do, we're going to see an explosion of these numbers over the next 5 to 10 years. The question is, does this process get exacerbated by vaccinating large portions of the population? That's a big question. And based on a small research study in Italy, they found a 28% absolute risk of people developing autoantibodies. When you put this across a population and you realize that autoimmune diseases are the great pretender, they don't present obviously. They have a whole variety of symptoms, and you literally have to be looking for it to find it. When you put that on a population, we are bound to be facing huge issues in the future. How do we mitigate that? I'm not sure, because in effect, the stuff that has been done has already been done. And when you add on to the fact that we are having high circulation of virus in regions that are highly vaccinated because their mucosal immune system is unable to prevent infection, therefore, you have an even greater risk, because every time there is a breakthrough infection, you increase the risk of multiple organ involvement. And that's where it leads me to the storm. And this is what I'm building the case for now. So, again, if you're listening to me, this is going to be ahead of the research. I am looking at the outcomes that are coming, and I'm looking at this spike triggered autoimmune response mechanism. That's what I call a storm. I think this is extremely serious, and we need to figure out how to manage it. We need to understand the mechanisms and we need to research it. That's the kind of work that needs to be done now to try and mitigate the damage. I'm not sure if we can reverse the damage, but potentially if we can identify who is at risk and put in place the right framework to protect them, maybe lifelong treatment, then it will still be protective against some of the complications that could come down the line. So we have huge challenges ahead of us. And I'd encourage everyone, before I finish, please make sure that you join us with this revolution. Subscribe to our newsletter. When you subscribe to this one, you will also get a free ebook on nitric oxide. And you can see this is an incredible piece of newsletter, tremendous testimonials, 5-star. We're building a community. We want this to be very valuable to people. So please join us in that journey as we continue to explore the science. The reality at the moment is that there are huge problems ahead. I don't think there's any easy way out of it. And you have to remember that this trajectory that I'm talking about when I speak of storm is not in a few months. This is over a period of years, a gradual increase. This is why I call it a storm surge. It just keeps on coming and doesn't stop. That's what we're likely to face. As I said, we need to find strategies to research, innovate, and mitigate some of the actions that occurred in the past. Have a great evening. Look forward to sharing more information with you. Remember to subscribe, remember to join our newsletter, and let's have a revolution in the way we approach healthcare. Thank you.